pharmacogenetics. So if you go to the doctor's office and then you got prescription, but not everybody have the same reaction to it, because some of them have normal response, so you get a drug, happily take it, and then get better. Great. But some of you actually have like, well, I don't feel still right, and then go back and doctors like, I don't like that doctor. I don't like the medication, sorry. And then some people actually have a very bad reaction to it. Sometimes you have a rash because of the drugs, make you more nauseated or diarrhea. So why is that? And then we wanted to actually see it from a genetic standpoint. So we checked the data, and then which one is the most well-characterized mutation exists in a particular genes. And then scientifically, they find it. Excuse me. So they actually categorize based on it. So responders is great, but if you have a certain gene mutations, then you might be categorized as a non-responders. And the different gene mutations is corresponding to the adverse reaction. So this is the pharmacogenetics. It's really, really short version to it, but hopefully pharmacogenetics help you to select the right medications and hopefully safe for you, and then also the tailored dosage. So tailored dosage is a very important part of it because, like me, I'm a smaller Japanese, but dosage guidance in the United States is 1 or maybe 2, it depends on the medications, but that's I've been given. But I have some mutations, so I got sick all the time. So I have to tell doctor, I have this mutation, so could you consider reducing dosage? So then I won't get sick. I want to get better, but I don't want to get sick with the different symptoms. So in the United States, we spend a tons of money. So this is the data from 2009, and the total $1.25 billion used in the medications. And I wanted to just focus on the top 5 healthcare expense. I'm sorry, this is really hard to read, but heart disease, cancer, mental disorder, and a trauma-related disorder, and a COPD and asthma, like a pulmonary disease. And I wanted just to focus on the mental disorder today. And inside a mental disorder, total 38% is used for prescriptions. And then when you go to doctor, if you have like some light depressions, you get Prozac. But Prozac, if you have it, Prozac are really, really strong inhibitor property. So if you have other drugs metabolized by certain enzyme, you have a drug-drug interactions. So nowadays, on the clinical setting, if you doctor order one drug and then order a second drug, there is a database pop it up. Well, there is a drug interaction, so be cautious about these medications. So that's great. But the caveat is that many people stop taking it. Even though doctors think the way of the possible toxicity versus efficacy, doctors make clinical decisions to say, still, I understand that, and then we'll explain to you that it's possible, maybe this is side effect, but this medication help you to recover from whatever symptoms you have. But in a mental disease related especially, they tend to stop taking it. And they don't really tell doctor, you stop taking it. So they call the medication adherence, which means don't stick to the patient, costs a lot in society. And a total of $300 billion a year in the United States, which is such a waste. And then 30 to 50% of patients don't take medications as they're directed because maybe toxicity, you don't like it, or it doesn't work. But it does work or not, it's not just your decision. You have to consult with doctor, and doctor make decisions. But many patients, they just stop taking it. And so pharmacogenetic testing is not just cool scientific evidence. They are actually very closely monitored and evaluated and identified which clinical benefit exists, and also compared to the cost Because the clinical situation, everything go back down to money. Because you pay for it, insurance pay for it, government sometimes pay for it, but has to be cost benefit. And the weighing the cost, providing the pharmacy 1 compared to B, or combination 1, 2, and adding 3, has to be evaluated really nicely. And the traditional way, unfortunately, in medical fields and the mental health, you prescribed one medication, didn't work it, you got second. Didn't work it, but they don't take the 2. They add more 3, 4, 5. So at the end of the year, you end up multiple medications, and you really hard to keep up with it because one of them have to take 3 times a day, twice a day, after, before lunch. It's really complicated. But hopefully pharmacogenetics help you to find the right medication in the first place and right dose, and so that gene test and the medication help you to reduce the number of medication you have to take, so the outcome per cost will be more beneficial. So right now, this is traditional way is more weighing, but this new approach is hopefully become a dominant in the clinical setting. Okay, so what's the pharmacogenetics testing for? So we have multiple genes testing for example, drug target itself, or some target-related genes, and also drug metabolizing enzymes. Drug metabolizing enzyme has so many enzymes identified, and very popularly tested for is a cytochrome P450 family enzyme. So we call that CY and the P called CYP. And then so we have a very famous CYP 3A4 and 5. And 3A4 and 5 exist in the gut and the liver, and the majority of drugs is actually metabolized by this enzyme. And the very polymorphic enzymes is the CYP2C9, 2C19, 2D6, and a little bit of 2C8 and 2E1, but considering how many drugs is metabolized by 2C9, 2C19, 2D6, there are 3 of them are very important drug metabolizing enzyme to test for. Okay, so I wanted to give you a quick example how actually help you to do the test. So this is a very famous medical Mayo clinical study, and this patient had a heart attack, and then also they are under the medication called warfarin, blood thinning drugs, and very popularly prescribed medications. But these medications sometimes have a complication because this drug is metabolized by 2C9 and a target to the enzyme called we call C1. It's a vitamin K cycle enzyme, and if you carry the mutations, one or both genes, probably you need to have a dose adjustment, which is recommended by FDA. So if you go to FDA website, there is a nice chart, very clearly said if you carry mutations, homozygote, go down to the 1 milligram, or consider avoiding warfarin in first place. And so this study was showing intervention of the study. So first, I wanted to orient you in the bottom parts B. This is really difficult to see. So the patient got tested, and then the bottom line is the genotyped group, and the top line is a control group. And then these horizontal saying hospitalization risk. And if you have the genotyped group, clearly less risk to get hospitalized. And then top A figure is showing that control group has less frequency to come back to clinic and whatever reason. So this chart to tell you that yes, there is a clear difference between genotype tested versus non-tested. But in reality, that's such a small percent and the graph. But if you are one out of certain numbers patient, go back to the hospitalized. You know it, doctor know it. Do you want to take a risk to be a 1% person to actually go back to hospital? See, that's the dilemma. It's come down to your decision making, because some insurance company won't cover the gene test. It's cheaper nowadays, but it's your decision. You have to actually involve in pharmacogenomic testing if you really wanted to take a chance. Okay? And then next, I wanted to show you the little bit of benefit on a psychiatry patient. So again, CYP2D6 is a drug metabolizing enzyme, and then this study showed 353 patients, and the intervention or not. And then if they knew that gene modification reduced the cost of the clinic is reduced by 28% for certain people, which means that really carrying the mutations caused higher enzyme activity or really low enzyme activity, meaning that you have a medication prescribed. Your body clears the medication too fast, so you don't have efficacy of the drug. Or poor metabolizers, you have prescribed, you're taking it certain time, but accumulation with drugs is way too fast, so you start having a toxicity. Okay? And if you have a UM, a PM, such mutations, then you have pay more, $4,000 to $5,000 higher cost, because you end up, you have a toxicity, you go back to clinic, you spend more money, or doctor says like, oh, it's not working because you don't have efficacy, let's add more medications. And so here is another example, CYP2C19. This is a smaller study, 104 people, and then showing a reducing the cost of 28% again for a certain mutation carrier. And other study was done in a CYPs, P450 enzyme and a transporter, and HR2A, this is serotonin receptor mutations. And then they found this patient have a 69% higher risk in a healthcare visit, and a 67% higher frequency to go back to medical visit. And then if you want to go more thoroughly tested, you can go get this Genecept test. It's a panel of the P450 enzymes as well as transport the genes tested. And that's helped the patient cost of $562 for 4 months. So there is evidence out there, but still, you might not be able to cover by the insurance. So again, insurance companies, they tend to deny your claim. You have to check with them first. But if you know that the risk, do you want to take a risk? You want to be the certain percentage patient, you have to go back again or suffer more. So it is your doctor's decision to pick the medications, but if you're willing to pay the little bit extra, couple $100 to test it, I personally, it's worth it. So I wanted to just show you the little bit of the challenges. Again, this is not really brand new, but very, very, very recent study in a very early stage in the clinical setting. Some big clinic or hospitals, they already implemented the gene information, so the doctors have a pop-up message saying, well, be careful with the patient because this patient carries certain mutations, try to avoid this drug, so forth. But not all the clinic has that information. And then I wanted to just touch base with just the legal issues, because this is a very new area. You have to know what your information is going to be. Are you discriminated against? Because well kept it. The security of the information is a huge issue. So again, what happened to data after you test it? And if you haven't carried the new mutations, for example, you go to the online and then order the whole genome sequence can be done in less than $1,000. You test it, then you find that you might have a really interesting genes. Do you keep it for yourself, or somebody else get a pattern on it to make a business? So we so-called nowadays precision medicine. We used to call it personalized medicine, but now they tend to switch to precision medicine. And this precision medicine initiative is a huge study. And precision medicine is creating a huge database for scientists to collect the data. And if you actually clear by a certain group of people, and then you can use the data to do the research on. And then President Obama announced this medicine, precision medicine initiative in 2015, and then put a huge amount of money. And privacy and security is a huge impact on the society. So Obama clearly said, yes, that's the first priority. We have to be careful about it. And this is a very important statement. If somebody does a test on me, which is Obama, or my gene, then that's mine. So, but that's not always, is it? So we have to make sure that. This is a very strong statement because up to then, nobody said that your gene information belongs to you. Okay? And so the information is securely stored. And if you actually participate in this study, then you become partners. You are not just a participant, one of the person and the subject. You are actually partners. You can get to the website and then you can collect whatever information you have. And to protect your privacy, this is a little bit more broad sense for it, but we have a GINA, the Genetic Information Non-Discrimination Act. That's help you to not discriminate against. Because if you carry the certain genes that lead to the disease, for example, like a very progressive disease, neuroprogressive disease, if company owner knew you cannot handle the very high responsibility work, do you think the owner take a chance to let you have the really responsible work? It's really gray line there. So GINA will help you. GINA is actually set, saying that you can't make a decision hiring or giving responsibility and whatnot based on the gene information. And the insurance company cannot hands on your gene information. So this is great, but this has a pitfall. The GINA does not cover the health insurance may ask genetic information. They can ask you about it. They cannot make a decision. They cannot create this, they cannot say no to cover you because of the gene information, but they can ask. And then this really weird, a small company, employees less than 15, that's not covered by the employee making decision or whatnot. The 15, nowadays it's really early stage company, less than 15 employees, that's here. So watch out for that. And then also this GINA doesn't cover the certain employees and the governmental employees, US military under TRICARE, this and whatnot. So there is a pitfall. And then to fill the pitfall, there is like a legal protections by state. So those legal protections exist, but not perfect. So that every time you go and you're interested in genes, you test the genes, go to clinic, test the genes and whatnot, you really need to read a small print and then make sure you sign on a paper you will understand. Because it might hurt you. One time we had our company had one patient come back and then she signed it to test it, but she didn't realize that's for gene testing. So, of course, we have to destroy all the evidence, all the data not existed. It's almost, we had said that, well, this we tested, but we deleted the whole thing. And then we have to make it the legal document, and then we did the right thing. But that's our responsibility to do so, but it's your responsibility to sign a paper you understand what you signed for. Okay, so gene's yours, you protect it, but you should understand your rights. And then pharmacogenomic testing is very new, and then total is 1,539 drugs is labeled, is accepted by US FDA, and only 137 has a comment regarding the pharmaceuticals. And how many we covered by insurance? Not much. And this is a very, very commonly accepted drug, clopidogrel, because clopidogrel is a prodrug, so has to be activated by CYP2C19 to actually have efficacy. So if you have a poor metabolizer with 2C19, you get drug, but nothing happens. Especially clopidogrel is a very serious drug. You have a heart-related disease, okay? So you have to know that. So the medications, it's called a medically necessary test. So if you go through the document from insurance company, watch out this phrase, the medically necessity. That's the word you stick to. You gotta really know that. So otherwise, we're talking about research purpose. That means they don't cover. So I don't have much time left, but I have one quick example. So case study and a hydrocodone treatment actually end up the fatal to the girl. 5 years old girl had a seizure since she was born, and she had a cold and ear infection. So she got prescribed valproic acid, which is for seizure, and also hydrocodone and then clarithromycin for ear infections. And then hydrocodone has a very nasty side effect, the vomiting, diarrhea, and whatnot, and then plus depression with breathing. So if you overdose, you don't breathe, no oxygen. Then hydrocodone is metabolized by CYP2D6 to hydromorphone, and also 3A4 to non-hydrocodone. And non-hydrocodone is inactive metabolites, and then further metabolized by UGTs to make glucuronide compound. And hydromorphone have therapeutic activities, and actually, in fact, you can get the hydromorphone as a prescription, and then that's further metabolized by UGTs to make hydromorphone glucuronide. And what happened to the girl, and why she passed away? Turns out, clarithromycin is a very strong inhibitor for CYP3A4. So practically, hydrocodone metabolism can't go this way to clear the body. And the valproic acid is a very broad inhibitor for UGTs. So that means this metabolic pathway shut down. This is also shut down. This is shut down. And only one clearing is hydrocodone to hydromorphone. Both of them have a therapeutic effect. Okay? Then it's really difficult to read now, but this girl is a carrier in the mutation at CYP2D6. And that mutation leads to her poor metabolizer category, meaning that this 2D6 pathway shut down as well. So after second day of the hydrocodone taking, total is only 30 milligram, but she found in the bed cold, and her death was announced at the clinic. So this portion, hydrocodone, clarithromycin interactions, should be available on the pop-up window. Hydromorphone to glucuronide valproic acid may be available on the pop-up warning, but another piece is missing is a 2D6, poor metabolizer information. So this illustrates to you that there is a data available, but doctors should know this pathway, drug-drug interactions, and the possibility of 2D6 poor metabolizing phenotype. So we have information, gene information, drug-drug interactions, and the medication list have to be all combined together and consider all the worst case scenario like this. And hopefully our company is working towards this kind of scenario. Now database exists and separately. Drug-drug interaction is one side of data. Drug-gene interaction is a separate data. But they don't actually combine together and communicate to each other. So that's what we try to do right now. So hopefully not too long future, we will have that service in the clinic. So then you can talk about it openly with your doctor and then understand your risk when you get the medications. Okay, so this is the last slide. So doctor will use the gene information. It's actually tailor your medications. So I think this picture is really illustrated really well in that sense. Okay, thank you so much.
Can you comment on the cost of this kind of testing, and can you do it on your own, or do you have to do it always through the insurance company? Can you get this on your own? Because I know you said you can do your own genomic testing.
Mm-hmm. Yes, doctor have to order it. But if you actually tell your doctors you will cover it personally, the out-of-pocket patient, then yes, you can. Yeah, we are towards more as a direct consumer system. And then other pharmacogenomic testing companies are towards that direction because the insurance company has their own science background people helping out to say no to it. But in my opinions, actually that will help them because once actually having one medications cause the failure that's talking about that heart-related medical decision is not great and end up go back and hospitalized or cause a fatal situation, that costs more money for the insurance company to cover it because others will cover it, right?
How much does it cost? How much is it tested?
It depends on the genes. Someone genes, few $100s, couple $100s, to full set with CYP enzymes, probably we talk about $700-800. But its price, there is no regulation about it. So if you shop around, you get better deal. And then also, I think we do it, and other companies also offering too. If you are not going through the insurance company, those like us try to figure out, cut down the cost, and then match up what you can afford. And then sometimes we cover the negatives because the test is done, and then we thought the one insurance company will help to support the cost, but they denied it later. Then we have to go back and ask the patient to pay for it, but they said no. Then we kind of start having a negotiation. So it's set retail prices available, but I think the bare minimum genes I would recommend is 2D6 and 2C19. Those are two enzymes are really important and very highly polymorphic, meaning the many mutations. So it's a very important gene test. Thank you.